think Judy Friedman, thank you so much. I very much appreciate being able to connect with everybody, still in a hybrid, but now again, kind of virtual mode. I have Washington, D.C. behind me. That's where I'm a neurologist and movement disorders specialist. Georgetown is not right behind me, as it usually is in my Zoom background. But Georgetown University Hospital, we have close to 14,000 Parkinson's patients and 14 movement disorders subspecialists. We have a big fellowship program. We love taking care of our patients and educating and learning and doing presentations like this so that we can continue to empower ourselves through this wonderful presentation, of course, powered by the Maryland Association of Parkinson's Support. We're able to then transmit hopefully a bunch of knowledge and a bunch of really important content through this presentation today. Today, we're going to talk about sleep and Parkinson's disease. I am Yasar Torres-Yaghi, as I mentioned. I'm an assistant professor of neurology. I am the director of a specialized clinic that takes care of patients with cognitive impairment and Parkinson's disease called the Parkinsonism and Dementia Clinic. And I really, really love taking care of my Parkinson's patients. My aunt has Parkinson's disease, and I diagnosed her at the age of, she was 52 years old when she was diagnosed. So not only do I do this for a living, but I have a very, very strong family connection to taking care of Parkinson's. So let's dive into sleep, which tends to be kind of this time in our day, in our evening, our 24-hour period where some might forget that a lot of things can happen during sleep, especially in Parkinson's. The other thing that we need to know about sleep and Parkinson's is that there's a lot that we can also do. If we can identify a problem, there's a lot that we can do to help. So all the problems that we're going to discuss today, hopefully will also have therapeutic solutions to the problem. But what I show you here is that Parkinson's disease has to do, generally speaking, it's a diagnosis that has to do with the UK brain bank criteria. And you have to meet these motor goals: bradykinesia, rigidity, maybe a tremor, difficulty with gait. There's different stages as things progress. And we know that it's always due to alpha-synuclein deposition that usually starts in the GI system and moves its way through the nervous system up to the brain where it affects our substantia nigra. But something that I didn't mention so far is a lot is hosted when it comes to sleep. An important part of the brain is called the pons. And that's a structure below the area of the brain that's affected during the tremors and rigidity and slowness of movement, the motor symptoms. The substantia nigra is in the midbrain at about eye level. The pons is right behind your nose and mouth. That part of the brain is very much a part of the brain that controls our body and our brain during sleep. And it controls our alertness during the day, and it controls our quality of sleep at night, and it controls our movement when we are laying in bed asleep and dreaming. And so as alpha-synuclein develops and progresses and grows and accumulates as we age, and because of our condition, that pons becomes more and more affected. That reticular activating system can be more and more affected. Here is where you see the midbrain, the substantia nigra, that holds many of our dopamine cells. You can see that here, right here, this area. Substantia nigra is called, in English, black substance, because those dopamine cells actually stain dark if you can find them in the midbrain. And those are the cells that are important for our mobility. And the substantia nigra tells our brain and tells the rest of our body to walk and move fluidly. Now, Parkinson's disease progresses, and I mentioned the pons. This area right in front of the cerebellum is affected. And it can be affected even early on in the Hoehn-Yahr stages. It can be affected in stage 1 and stage 2, where that's where we start seeing that alpha-synuclein deposited in the pedunculopontine nucleus, right there in the pons, a very important sleep center. And you can see alpha-synuclein developing in the reticular activating system, along with other important cell structures within that pons, specifically the serotonin center. The serotonin center is called the nucleus of Raffi. Serotonin center has very much to do with your circadian rhythm. And so even early on in early stages of Parkinson's disease, that sleep area and that alertness area in the pons can be affected. This is a way of looking at the prodromal phases of Parkinson's. So as Parkinson's disease progresses over time on the x-axis, what you're seeing there is that the neurons in your brain become more and more affected. Specifically, early on, even before the tremors, rigidity, and slowness of movement that we tend to diagnose Parkinson with, before that, even before the diagnosis of Parkinson's disease due to the motor symptoms that meet that UK Brain Bank criteria, sleep can be very affected. Your sense of smell can be affected. Your mood can be affected. Your autonomic nervous system, that's the part of your nervous system that controls your organs, like your bladder. All of these functions serve a role with sleep, including the autonomic system, including your mood, right? So as your mood becomes more and more affected, even sometimes decades before Parkinson's disease is diagnosed, that can really, really disrupt your sleep. So I know all of you attend many, many of these presentations that are hosted by MAPS, and you're learning and you're empowering yourself with knowledge like you should. But I know, and I'm sure a lot of you have heard about the non-motor symptoms or the premotor symptoms. But what I'm showing you here is that over time, we tend to have more and more disruption of those important sleep centers. In particular, the most widely documented premotor changes in Parkinson's disease patients include REM sleep behavior disorder. And we're going to dive into why that happens. But we know that those chemical centers in the brain, the chemical centers that help augment dopamine, adrenaline or norepinephrine, acetylcholine, serotonin, all of these disruptions can contribute to the non-motor problems. We tend to think about the non-motor problems as first starting in that GI system, if you see that, then affecting our olfactory nerve, then our cardiac and autonomic system, but then also you see this black and white picture of someone sleeping. If you look, remember, that sleep center is very much inside that pons. Now, we know the types of things that we think about early on in the condition can evolve over time as well. Things like depression, the sleep disorders like REM behavioral disorder, or just sleep fragmentation. It can be hard to stay asleep. It might be easy to fall asleep, but it's hard to stay asleep. Nocturia, our bladder can be affected. Nocturia means that in the middle of the night, we need to get up and urinate a lot sometimes. And patients might think that it's due to their prostate, but in fact, it's due to that nocturia because of that sleep disruption that can occur, that autonomic nervous system disruption. And we all know that if you don't sleep well, your next day is not going to be good, right? You're running on empty. Your cognition can be affected. So all of these things are intertwined and very, very important to address. What else can happen during sleep? Well, before falling asleep, our patients might experience restless leg syndrome, right? Restless leg syndrome is something that might happen. As you see here in the sleep disturbances that can occur, aside from having difficulty falling asleep and that fragmented sleep and REM behavioral sleep disorder where we're acting out our dreams, we can also have that restless leg syndrome, which can make it really hard for us to feel comfortable. We feel like we need to get up and walk around. Also, we might feel fatigued all day long because we didn't sleep well the night before, and that can contribute to our overall feeling of just feeling crummy on certain days when we have low energy. Remember, depression, anxiety, psychosis, and cognitive impairment all have to do with the neuropsychiatric and cognitive changes that occur. And sleep disturbance is under that umbrella. So understanding this study became very, very important when I was learning how to be a movement disorder specialist. 34 years, including preschool, 2 years after the years of 32, you're still well into your 30s trying to become a movement disorder specialist. And I remember learning about this clinical trial in one of our journal clubs. And what this study did, it was a very important study called the PRIAMO study. And it was a multi-center survey done in Italy. More than 1,000 patients were surveyed to look at their non-motor symptoms. And what we see here is that at least 98.6% had one or more non-motor symptom. And this can range in any part of the condition, either early on or later. And what we see here is that 64% of the people who filled out the survey, of the more than 1,000 patients, reported some degree of sleep disruption. And as you see here, as the Hoehn-Yahr disease stage progresses, if you follow sleep towards the right, what we see is stage 1, Hoehn-Yahr, maybe 47.9% of patients are affected by sleep, but it keeps growing. As the disease progresses, now we're in stage 2, we have 60% of patients, then 75% of patients. And once we're in stage 4, stage 5 of Parkinson's disease, about 81% of our patients might experience some sleep disruption. This is showing us, as part of the PRIAMO study, that sleep is more affected as cognitive impairment continues to progress as well. So if cognitive impairment progresses over time, we might expect to have more sleep disruption and more sleep disorder. This is another way of looking at the non-motor symptoms and how they advance over time. And what I can show you here, and what I want to kind of present to you, is that REM behavioral sleep disorder can be seen at minus 10 years. So a decade or more before we start noticing the diagnostic symptoms of bradykinesia, rigidity, and tremor. And as the condition progresses, we may see more and more sleep disruption. So how do we tend to look at the clinical manifestations and the evolution of these symptoms? And what we tend to see here is that we might see autonomic disruption, but the sleep disruption can occur. That red line all the way on the left, that S-shaped curve, is showing us that most likely, based on the way alpha-synuclein progresses, REM behavioral sleep disorder may be one of the first things that we might experience, alongside changes to our cardiovascular state and our lack of sense of smell. And it's hard to diagnose all the things that can go wrong in Parkinson's disease when it comes to sleep. Sometimes you need an EEG, sometimes you need an EMG, sometimes you need a clinical diagnosis and different types of scans and tests that can help us understand what sorts of things can go wrong in Parkinson's at night. But don't fret. A lot can be done to treat the symptoms. All the things we're talking about, I want us all to remain positive and optimistic. Don't fret, because remember at the beginning I said, we identify the problem so that we can come up with the therapeutic solution. And that's what this is all about, because we're going to talk about the things that we can do to help and improve our sleep quality pretty soon. But we still have to understand what's going wrong so we can fix it. Parkinson's disease isn't the only problem. How many of you have heard of AGE? That's a diagnosis that no one can get around. It's called age, AGE. And as we get older, and as we have issues from just aging, what we tend to see is that our REM sleep is reduced over time. And it's harder for us to have restorative sleep just due to aging. So aging also plays its own role. But when that happens, all of those changes to our sleep patterns make it so that we have less energy during the day. We may want to nap during the day, right? Some people say, Dr. Torres Yagi, I hit a wall. I hit a wall at 2 or 3 p.m. It's that 2 o'clock feeling. What is that? There was a funny commercial about the 2 o'clock feeling. Everyone at 2 or 3 p.m. just hits this wall, and patients may want to fall asleep and just get so tired. Now remember, that's because of all of those changes that happen. Here are all the things that can affect us during our sleep in Parkinson's. And I put it all down here because I want us to kind of think about it. Nocturia, urinating at night, right? That might be something independent from your prostate. What about wearing off in the middle of the night? We feel like we're tremulous, stiff, rigid. It's hard to turn in bed. All of those things can happen in sleep in Parkinson's because our levodopa isn't optimized in the evening hours. Remember, dopamine is highest in the morning. When you open your eyes and the sun comes in on a nice sunny day like today, it tells your brain to produce dopamine, okay? Let's say you have a coffee. That makes your dopamine surge even more. Let's say you turn on your favorite song in the morning. I am listening to Jim Croce. So this morning I put on Jim Croce. I had a cup of coffee. It was a nice sunny day, and my dopamine was flowing on my way to work. I listened to it in the car, and it was a nice songs. But I tend to like music more in the morning. Why is that? Because our dopamine is flowing in the morning. At 2 or 3 in the morning, at 2 or 3 at night, which basically in the morning before you wake up, when the sun is down, your dopamine is at its lowest point. And that's not an uncommon time for our Parkinson's patients to wake up feeling restless, stiff, where it's hard to turn in bed. We might feel restless legs syndrome, where it can happen where we feel like it's hard to fall asleep. We can feel more depressed and anxious at nighttime as well. That's when we have lower dopamine levels. Dopamine helps us feel better so that we're not stressed and anxious. That's why people ruminate. And when they have anxiety, people can ruminate at night. It can keep them up, because they tend to feel more stress at night. And then all of the things that have to do with respiration and changes at night, that lower respiratory rate can also affect the way our body is getting oxygen and things like that. So all of these things are very, very important, and they're not easy to detect unless you ask, unless you understand. But so these are the things in terms of sleepiness in Parkinson's. If you look over there on the right, kind of that orbit-like schematic, what I'm showing you there is that a lot contributes to sleepiness in Parkinson's. Patients might say, Doctor, I'm tired. And I say, well, is it exhaustion? Is it low energy? Or is it true somnolence, like you feel sleepy? Because there's a distinction that needs to be made. Our patients might feel sleepy during the day. They have difficulty maintaining or initiating sleep. And then there are all these factors, all the medical comorbidities, things like sleep apnea can happen more regularly in Parkinson's disease. Then we have the disruption with our REM cycle. Then we're on medications sometimes that can keep us awake or change our circadian rhythm. And then, of course, all of the things that I mentioned. So this is a very multifaceted conversation, right? Has a lot to do with how we feel. Sleep is very important. Sleep quality. If we look at sleep quality, we know that in Parkinson's disease, our overall sleep quality is reduced because of all of the things that we mentioned, including psychosis. Remember, people that might experience some visual hallucinations or delusions can experience them more at night. So let's look at insomnia and understand why that might happen. Insomnia can happen in about 50 to 80% of patients with Parkinson's disease, and it can contribute to our overall feeling crummy, feeling bad, feeling low. It can worsen our depression or our irritability. It can worsen our concentration. It can make it so that it's harder for us to remember things, and it can make it so it's harder for us to execute tasks or read or even exercise. So what do we do for sleep dysfunction in Parkinson's disease? Well, first of all, we make sure that we've had a sleep study. So if anyone is snoring at night in our Parkinson's clinic, I always ask, do you snore? And patients might say, nope, not at all, doc. But then our care partner will sometimes nudge our patient or nod, yes, of course, doctor, he or she does snore, but he doesn't know it, but I know it as his bed partner. So you always have to ask the bed partner too. Remember, sleep dysfunction, it's very important to treat not just the sleep apnea, as that contributes very much to our sleep disruption and sleep dysfunction, but you want to make sure that you're not utilizing medications that can cause a hyper feeling. You want to make sure you're utilizing extended release formulations of carbidopa, levodopa at night. You want to treat depression and anxiety. You want to treat psychosis or delusion so that patients can sleep more soundly without having all that sensory input. And you may want to improve their sleep quality. Sometimes even surgical treatment modalities like deep brain stimulation can help optimize your motor function overall, and that can be very helpful. So what are these management strategies that don't have to do with medicines? How do we improve sleep hygiene? Limit later in the day naps, right? So that you're not sleeping too long towards the evening hours. You want to limit caffeine at the end of the day. Alcohol, unfortunately, disrupts our sleep and our REM, and it makes it so that we don't go into as deep sleep as we should. So you want to reduce or stop alcohol. You want to exercise as much as possible so that you do get tired and you feel comfortable at night. You want daylight exposure. You want to open those curtains, especially in the winter months. That helps regulate your sleeps and your circadian rhythm. You want to adhere to a day and night routine, right? Try your best to stay on a routine and try and make your bed mainly for sleeping. You don't want to do too much in the bed. You don't want to watch TV. You don't want to, do different sorts of activities. You don't want to build things in the bed and stay in the bed. The bed needs to be a trigger to your brain for sleep, okay? And then, of course, we talked about optimizing medication management using extended release formulations, adding once a day, longer acting formulations of medicines. You want to make sure that in the middle of the night, if you wake up and you're having an off episode, you can use as needed medicine when that happens. Reducing fluids at night so that you're not up urinating. Reduce caffeine because caffeine makes you urinate. So all of these things have everything to do with how you sleep. So REM behavioral disorder is another concept that we need to talk about. And that part of the brain is called the pedunculopontine nucleus. And our problem in Parkinson's is that we act out our dreams. We might talk in our sleep. We might orate. Today I saw a patient and his wife said, he's giving lectures. He was a professor. He's giving his lectures in his sleep. And I learn a lot because my partner is talking, and I've learned so much from him sometimes in these sleep orations. But in general, it's hard because I know that his movements wake him up in the middle of the night. And so it's important when thinking about treating REM behavioral sleep disorder, first identifying it and asking about it, but then making sure that you're avoiding triggers such as alcohol, and some antidepressants can actually trigger them. You want to make sure maybe if you're having augmented REM behavioral disorder that you may want to think about better safety rails, minimizing clutter in the bed area, pillows on the floor, or sometimes we have to consider sleeping alone because the movements can be more severe. The way we treat it with therapeutics is with melatonin and or clonazepam. There are other agents that can be utilized, but those two are the major ones that we think about. Now, this is a big study that looked at Parkinson's patients with REM behavioral disorder. It's also important in patients that have REM behavioral disorder to make sure that you've also diagnosed and detected any cognitive impairment, because MCI can be frequently seen. MCI means mild cognitive impairment, can be frequently seen in patients that have REM behavioral disorder. And so anyone that has RBD should also be tested periodically for cognitive impairment. Now, restless leg, hopefully many of you haven't felt it, but restless leg can feel very uncomfortable. It can lead to an irresistible urge to move your legs. You can get these tingling or electric sensations in the legs, can be very uncomfortable, make it hard to fall asleep. And people have to walk and get up. Sometimes they're about to fall asleep and they feel this urge to move. That's restless leg syndrome. Now you treat that with dopaminergic medicines like dopamine agonists or levodopa, or some formulations of gabapentin, things like gabapentin, Lyrica, Horizon. There's an extended release gabapentin called Release that can be utilized. And here you see that if we can detect cognitive impairment like we should in Parkinson's disease, especially in those that have REM behavioral disorder, it's important also to make sure that if you have problems with your cognition, that you detect it, but also any cognitive impairment should also have your doctor and your healthcare team prompt them to look for sleep problems like REM behavioral disorder and sleep apnea. Remember, there's a lot of oxygen changes that happen because of sleep apnea. And those oxygen changes can make it so that you're cognitively more impaired. So an actual treatment for cognitive impairment is a CPAP machine, that positive pressure mask that can be placed for sleep apnea. So number one, a sleep study will diagnose sleep apnea. But how do we treat sleep apnea? We talked about the positive pressure machine, but we also need to avoid the substances that make it hard for us to sleep. Weight loss is very important. Weight loss can actually reduce sleep apnea tremendously and avoid you having to use a CPAP machine and avoid you from having to go through sleep studies. And it helps you, when you lose weight, it makes it so that your body and your chest wall more easily opens, so it's easier to breathe. Things like oral appliances can be helpful for sleep apnea. And then there's surgical treatments for sleep apnea as well. Now, fatigue is so multifaceted, and we call it nonspecific. It has to do with your diet, your mood, your exercise, your drug or alcohol intake, the amount that you do throughout the day. You know, if you're a working mom and you have Parkinson's disease, I'll tell you, my youngest patient's 27 years old. She had 2 kids, and we walked her through how to do it. But if you're not sleeping well, your Parkinson's is going to get worse, and you're going to feel more fatigued. So all those obligations of being a mom, taking care of kids, or if you're taking care of a loved one and you have Parkinson's disease, that's exhausting. Your environment, your stress level, your workplace, the level of dopamine that you get from your social environment is very important. What gives you dopamine? Love. Love, 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 love. Hugs give you dopamine. Kisses give you dopamine. I just saw a patient and his wife today, and she said, his wife told me the patient was so wonderful while they were visiting their grandkids at a bar mitzvah. They went for their grandkids' bar mitzvah, 14-year-old. They spent the whole week with their grandkids. They had a wonderful, wonderful, wonderful time. They came back, and he felt like he didn't have any Parkinson's symptoms. I think his dopamine was flowing. You know, love and togetherness is very, very important. So seek love and togetherness and positivity. What about fatigue during the day, feeling tired, mental tiredness? Remember, the most important thing that you can do for fatigue is sleep better. And how do you sleep better? You exercise better. So you have to treat the fatigue. And then you need to make sure that the fatigue isn't related to other things, such as drops in blood pressure and things like that. So what else can I do to treat my fatigue when it comes to Parkinson's disease care? Exercise, walk, try and regulate your naps. Don't take too long naps. Don't take them in the evenings. Make sure they're about 10 to 30-minute power naps. Eat colorful foods. That's very important. Colorful foods. Go back to the Mediterranean diet. Think about the low quantities and high fiber. Things like beans and legumes can be very good for you. Remaining socially active and connected. Planning your day and engaging in a routine. How do we understand our sleep quality? We write it down. Write it down. Go into your doctor's office or your healthcare team and tell them, hey, I'm not sleeping well. Oops, sorry. I'm not sleeping well. Think about these questions. What time did you go to bed? What time did you try to go to sleep? What time did you fall asleep? How many times did you wake up at night? How long were these awakenings? Think about all of those things, okay? Now, it's important to treat mood symptoms. How do we treat mood symptoms? We use dopamine agonists, monoamine oxidase inhibitors, tricyclic antidepressants can be helpful. That can also help you fall asleep. Selective serotonin inhibitors like citalopram and sertraline can be helpful. Remember, all of these things can help treat our mood, which can make it easier for us to fall asleep. And I'll have us kind of look just through this, but all of the things that have to do with fatigue, like orthostatic hypotension, can be treated. Remember, fatigue may be related to sleep, but it can also be related to low blood pressure. You can use fludrocortisone, midodrine, droxidopa, and you want to make sure that you're treating all of the other things that can happen, like constipation and drooling, which can affect our sleep. All of those things can make it uncomfortable for us while sleeping. So how do we treat insomnia? We think about controlled or extended release formulations of levodopa. Dopamine agonists, the extended release dopamine agonists like pramipexole can be helpful, rotigotine can be helpful. You may want to use medicines to help you fall asleep. You might want to use melatonin. Melatonin doesn't just help REM behavioral disorder, it also helps you fall asleep. And it can help regulate your sleep rhythm. You can think about CPAP machine and or reducing all of the things that have to do with caffeine intake and things like that, because that can help you. Now, these are the just summaries of the things we utilize for treating depression and sleep. Melatonin, benzodiazepines like clonazepam for REM behavioral disorder. We talked about sertraline. We talked about escitalopram and citalopram. But we didn't talk about mirtazapine or trazodone. Those two medicines are actually antidepressants, but they can actually make you sleepy. They're given at night. Many antidepressants activate you and they give you energy. Now, what did we say at night that can also happen? Psychosis, sundown can happen in some patients where they can get confused and that can be agitating and irritating. So it's important to treat all aspects of the condition, including if there are some underlying delusions or psychosis. That can be very, very helpful. So what do we utilize for psychosis treatment? We can use pimavanserin, quetiapine or Seroquel can be helpful. That can also cause some somnolence, and clozapine. Those are the medicines that we use. So let's think about treating all aspects of the condition. And we are approaching our Q&A portion. I wanted to do a rapid run through of sleep and all the things that can go wrong, but also hopefully we focused on the treatment options too. Now I'm going to stop here, share, and I think we're going to do some Q&A, right, Judy? Judy, you're on mute.
Okay, thank you. So one of the questions that people submitted was, is melatonin a good sleep aid for Parkinson's?
Yes, wonderful question. You got it. Did you see in the slides where I talked about melatonin? Melatonin can be given at different doses, can be started at 1 milligram immediate release, can be given in 3 milligrams, at 6 milligrams. You betcha, melatonin is a natural chemical that we have in our bodies, and it can be given. It can help with sleep onset insomnia and sleep maintenance insomnia. What's the difference? Sleep onset insomnia means it's hard to fall asleep. Sleep maintenance insomnia says, some patients say, hey, I fall asleep pretty easily, but 2 hours in, I'm awake. I have sleep fragmentation. I can't maintain my sleep. So melatonin can be utilized. Now, an important trick might be to take melatonin an hour or two before bedtime if you're having trouble with sleep onset insomnia, because it can take an hour or two to kick in at night. So you may want to take it a little earlier than right when you hit the pillow. Also, there's extended release formulations of melatonin, can be given at 5 or 10 milligrams. The most common concern is feeling groggy or sleepy during the morning hours or during the day. So you have to make sure that you're utilizing medicines, but you're not overdoing the dose so that you're not sleepy the next day.
Okay, can you hear me?
Perfect.
Okay, good. So another question is, my dad is fixated at night on small things and inadvertently avoids sleep at all costs. Is this an effect of Parkinson's? What can we do to help him rest? Sleeping aids have made him sluggish and almost appear drunk, slurring words and unable to move.
Yeah, it's hard. You know, I think what we hopefully talked about were all the things that can go wrong, right? Sleep onset insomnia, staying asleep at night. But I'll tell you, one of the most fundamental strategies that we utilize in our clinic to improve sleep, one of the most fundamental strategies is making sure that we've optimized the dopamine tone at night. You need to make sure if a patient's on a medicine if carbidopa, levodopa, immediate release 3 times a day, remember, odds are that that immediate release carbidopa, levodopa has worn off in the evening hours. And patients, when they're at low dopamine levels, they feel uncomfortable and they can't sleep. They actually might not be able to put their finger on it, and the family may not even be able to really explain it. But what I can tell you is that if we optimize dopamine tone, patients tend to sleep so much more soundly. So a medicine like an extended release medicine at night tends to be a good option, especially in patients that might have trouble staying asleep. They find it hard to turn in bed. They feel stiff. They feel restless leg syndrome. They feel like they're urinating a lot at night. Remember, the bladder is a muscle. And just like your muscle, like your feet or your calves can get stiff, so can your bladder. And so it's pushing down in the middle of the night because it's stiff, just like your body. So if it's been 4 hours or longer, 6 hours since your last dose of levodopa, and you actually feel your Parkinson's symptoms are returning in the middle of the night, odds are you either need an extended release carbidopa, levodopa, and or not just in isolation, you may also want an on-demand treatment. Either take an extra tablet or capsule of your levodopa, or you may want to use an as-needed therapy, one of the inhaled levodopas or the sublingual medicines or the injections that can help get us out of an off period in the middle of the night. Let's not forget, off time happens at night too. You know, actually, one might argue that it happens just as often as at night as it does during the day, or maybe even more.
Okay, here's a question. Could you say some more about addressing sleep with Lewy body dementia?
Yeah, so Lewy body dementia is a diagnosis that's multifaceted. It has pillars. In order to diagnose Lewy body disease, and I'm the Lewy body disease specialist at Georgetown, and so we have a specialized clinic that evaluates Lewy body disease or Lewy body dementia patients. And the way we diagnose it is based on clinical pillars. The first clinical pillar is Parkinsonism. So you need to have Parkinson's motor symptoms. The second is cognitive change or cognitive impairment. The third is fluctuating cognition. Some hours you're more cognitively powerful than others, or some days might be better than others. But the fourth pillar is REM behavioral disorder. REM behavioral disorder is one of the 4 pillars in diagnosing Lewy body dementia. And so it's important to detect REM behavioral disorder. Remember, in my lecture that I went very quickly, and it was very high level stuff, because I was showing you data, REM behavioral disorder happens more in people with cognitive impairment. So as cognitive impairment worsens, so does REM behavioral disorder. And so you want to do your best whenever you're trying to diagnose REM behavioral disease, REM behavioral disorder, and Lewy body dementia. You need to try and find that correlation, and you betcha you want to treat it. You want to treat the symptoms with melatonin, and or oftentimes you're utilizing more than one medicine. You may want to also think about clonazepam if it makes sense, if it's indicated. So yes, so Lewy body disease and dementia is a different diagnostic entity than Parkinson's disease with dementia, but it's important to diagnose. Also, Lewy body dementia and disease, oftentimes there's a lot of neuropsychiatric symptoms, psychosis, paranoia, depression, and anxiety. Those are the things that you need to make sure you're treating. Now, all of these things have treatments. So when I mention these things, I want you to remember that all of these things can be treated. And Lewy body dementia can be a manageable disease, just like Parkinson's, if you find that right combination of therapy.
So here's another question that doesn't have just to do with Parkinson's, but still. How can we reduce worries about the many insecurities that intrude on my sleep? Not mine, but this person's worries about inflation, global warming, financial insecurity, exacerbated by increasing medical needs and costs, all of the things that I need to do to make me do better, like healthy food, incontinence products, physical therapy, speech therapy, counseling, etc. A community where a large number of people refuse to be vaccinated, wear masks, or social distance. That's an all-encompassing question, isn't it?
Did I write that question? It sounds like me, you know? Yeah, you know, you're right. I think about those things too, and it's very, very hard. And we have to utilize both pharmacologic and non-pharmacologic measures because you're right. The world right now is in a very difficult place still in the midst of a pandemic, and all of the things you mentioned, you know, you're right. However, we have to work on our mental health because we have to be happy despite all of the bad things and the hard things that are happening in the world and in our life. We have to find a way so that we can combat Parkinson's, so we can sleep better, so that we can do better. You know, ultimately, in the long run, we have to sleep well. And there may be a time and place to think about things and to kind of deliberate about all of the things that you mentioned. But at the same time, we want to try and make nighttime really not the time where we think about those things, right? That said, dopamine is at its lowest point in the middle as the night progresses. And that's exactly when we start feeling those anxieties. So I think it's important to address and diagnose those feelings that you have and see there may be utility to diagnosing them and treating them. The other thing that's very helpful in making it so that our stresses and our anxieties get put where they need to be put, so they're not in the forefront of our mind. Things like stress reduction and wellness, meditation, exercise, all of those things make a big difference so that we can combat the things you mentioned, so that we're not necessarily sacrificing our sleep because we're thinking about all the things that were mentioned. There's a time and a place, and I'm not saying that those things are not important. They're very important to think about and try and kind of sort through so that we make our world a better place. But maybe at nighttime, we want to try our best to kind of put that aside, compartmentalize it, and utilize all the tools of wellness so that we can feel that kind of improved sleep at night.
Here's another one. Patient believes that they are sleeping all night long, but in reality, they are up all night, fixated on delusional thoughts. For example, needing to write things down, finding the TV remote, messing with a flashlight. He has taken melatonin, prescription sleep aids, lorazepam, etc., looking for advice on how to help with his sleep so his caregiver can rest.
Yeah, it's very hard, and that's why I put it in there, right? When we talk about the neuropsychiatric symptoms that occur in Parkinson's, things like delusions or psychosis can keep us up at night. And specifically when the night is there, that's exactly when they come. It's called sundowning, where confusion can happen and then it stays there. And so it's important to address it. I can't speak to any specific case in this presentation, but what I can tell you is if there is some sort of symptomatology like you mentioned, it's important to tell the healthcare team so that they address it. We did discuss all of the medicines that can be utilized to treat delusions and neuropsychiatric symptoms. Parkinson's disease, psychosis, and delusions can be treated with pimavanserin, can be treated with quetiapine, and some other medicines.
Here's another one. I suffer from insomnia. I have to use sleeping pills to get any sleep. Are there any drugs available that will help you sleep and keep you asleep? And why do so many health professionals try to get you not to use sleeping pills when they are the only thing that helps?
It's tough, and it's a double-edged sword, as is everything, unfortunately. The concern mainly is that as we get older, it's harder and harder for us to metabolize, specifically sleep aids and the types of the drug class of benzodiazepines, which are like Valium and clonazepam and lorazepam, but also the sleep aids, the actual sleep aids. Another concern with them is that if you need to get up in the middle of the night, if you're already a Parkinson's patient that has trouble with your gait and you wake up in the middle of the night, let's say just to go to the bathroom, it can increase your fall risk. There is a relationship between all of these medicines and increased falls. So it's very, very important that we're monitored and that we understand the risks when taking these medicines. Now, that said, right, we need to sleep. And so we need to find the reason why we're not sleeping. There are plenty of medicines. I even mentioned non-hypnotic medicines, meaning non-true sleep aids, medicines like antidepressants that might be helpful, right? That can make you feel sleepy. There are some antidepressants that can make you feel sleepy. In fact, taking an antidepressant like an SSRI even during the morning, which actually activates you, a medicine like escitalopram or citalopram, which are given in the morning because sometimes they can be activating, meaning not make you sleepy, actually give you energy. Taking those in the morning has been shown to actually regulate sleep rhythm and improve circadian rhythm at night. So even if you're taking an activating medicine in the morning, it can help you so that you're sleepy enough and that your sleep quality is improved at night too.
And another one, how to overcome daytime fatigue after improving sleep with acupuncture the night before.
You got it, because daytime fatigue is multifaceted, right? So you want to make sure, number one, anxiety and depression can cause daytime fatigue. You want to make sure you don't have sleep apnea at night. So you want to kind of address all of the sleep disruptions and the sleep diagnoses that I mentioned. REM behavioral sleep disorder can affect your sleep quality. Vivid dreaming, not optimizing your levodopa regimen at night can affect your sleep quality. Neuropathy or just tingling pain-like experience can interrupt with, can affect your sleep quality. So it's really a multifaceted approach. You want to improve daytime fatigue, but you need to detect what the cause is. Oftentimes, it's not just one thing, it's multiple things. You want to stay hydrated to make sure that it's not orthostatic hypotension that's causing daytime fatigue. Remember, our patients can have low blood pressure, and that can feel like fatigue. So there's all these reasons. You have to determine and figure out what's in fact causing the daytime fatigue. And remember, fatigue is different than somnolence. Daytime fatigue is low energy. Daytime somnolence is, in fact, actual sleepiness. And they're two separate things.
Okay, another one. I don't know that I can pronounce this drug. My husband takes Rivastigmine for Lewy body dementia, and he found that taking the patch off before bedtime allows for a better night's sleep. Is there any data to support this? Would he have better mental clarity in the morning if he kept the patch on all night? But we both think the patch causes sleeplessness.
You know, it's a good question. Generally speaking, rivastigmine is the medicine you mentioned. It's one of the best, most studied medicines in Parkinsonism and in Lewy body dementia, because it's a patch and it's transdermal. Well, they have a transdermal system. You still may be taking theirs an oral formulation. But in order for rivastigmine to work, the goal is to keep it on at 24 hours. Now, there may be different times that it can be given. Speaking to a clinician about when to put it on might be a helpful tool, a helpful step, like taking rivastigmine in the morning or at night, depending on how it's affecting each person's cognitive capacity and or alertness. If rivastigmine is contributing to sleeplessness, rather than necessarily stop a drug that one is tolerating aside from sleeplessness, changing the time. So talking to the physician and the healthcare team about your specific case would be important, and talking about that exact scenario, so that they may just need to change the time. But rivastigmine is the best studied cognitive medication that we have for Parkinsonism, because it increases acetylcholine and it has a transdermal system that was well studied, has a lot of evidence. As the Lewy body dementia specialist at Georgetown, we do tend to utilize rivastigmine transdermal very regularly.
And here's another one that doesn't seem to be about sleep, but please elaborate on the role of the GI tract in PD, and are probiotics recommended? Also, does poor blood sugar metabolism and insulin resistant, is that prevalent in PD patients?
Great question. We do have GI disruption. We know Parkinson's disease characteristically starts in the nervous system of the gut, the Auerbach plexus, the myenteric plexus. The nerves that are in the muscle of the gut are affected. Constipation is a problem. Decreased emptying of the stomach contents into the intestine are affected. That can reduce our absorption of the carbidopa-levodopa regimen that we so much rely on. And so we're swimming against multiple tides when it comes to the GI system. And so it's something that does need to be addressed. I mean, I would always try to optimize bowel regimen and bowel movement frequency in my patients. I don't think there's a full consensus on whether or not probiotics are recommended. However, based on clinical care, probiotics, if there is some utility and it doesn't harm the person that's taking it, then I wouldn't be against it at all. Probiotics can be healthy for the gut, and we know that there is a strong relationship between gut and brain. But I would actually speak to a GI specialist, because there's different kinds of probiotics. It's important. There's different ways to obtain probiotics through either diet or through supplementation. And so I tend to, when I encounter that question, I tend to rely on my gastrointestinal, my GI colleagues for their input. And when it comes to sugar metabolism, there is some relationship between sugar changes, perhaps, and neurologic state. That's kind of a general way of answering it. We know that there are some clinical trials ongoing looking at diabetes medications to see if they may help. In fact, in Parkinson's disease, a medicine called exenatide is being studied. We have a clinical trial. That clinical trial is ongoing at Georgetown with some of our patients. But also sugar, if you're hypoglycemic, it can contribute to fatigue. And if you're hyperglycemic, in fact, it can contribute to dyskinesias. So there is, based on sugar and energy and how it affects your overall metabolic rate and stress level, there is a strong relationship between stabilization of sugars and maintaining overall Parkinson's disease control.
So it's about 8 o'clock, but I think maybe there's time for one more question here.
Sure.
I sleep good from when I go to bed, anywhere from 11 to 12:30, but then I usually wake up between 4:45 and 5:30. Since I'm awake, I use the bathroom, and then I can't get back to sleep. Some say to take a Sinemet. That's the only medication I use. But as I have a swallowing problem, I was told to sit up for 30 minutes after ingesting any medication. Should I just start my day then and take a nap when I'm tired, sometime before noon?
It's a wonderful question, and it highlights kind of what we talked about. Remember, so I tend to ask the medical students and the residents and fellows that I teach at Georgetown, what's the most common Parkinson's disease sleep disorder? And the first thing that comes to mind is REM behavioral disorder. That's certainly disruptive, but the most common sleep disorder in Parkinson's disease is sleep maintenance disruption, sleep fragmentation. Patients might be able to fall asleep, but they can't stay asleep. And in cases like that, we have to make sure that our patients aren't wearing off in the middle of the night. And that's why you've heard about taking an extra Sinemet, but there's so many other strategies. Utilizing combination therapy, utilizing medicines, perhaps in combination with IR, can be helpful with the carbidopa-levodopa. In your case, I would urge you to speak to your healthcare team to see if there's another medicine that can be utilized, an extended release formulation at night, so that you have more dopaminergic tone in the middle of the night. As needed therapies can be helpful for wearing off if that's what's happening in the middle of the night. So things like inhaled levodopa, sublingual, apomorphine, the injectable, these are things that get you from an off state to an on state more reliably within 10 to 20 minutes rather than waiting for the carbidopa levodopa to get swallowed and absorbed and then go from your gut to your blood to your blood to your brain. That takes time. Sometimes it can take 60 minutes for that to happen or longer. Another strategy is to utilize as maintenance adjuncts, right? So monoamine oxidase inhibitors, dopamine agonists, A2A inhibitors, COMT inhibitors, things that help that are once a day and give you foundational dopaminergic tone so that you don't dip as far down, so that if you do have an off episode that wakes you up, you're not going as far down because you have other medicines that are 24-hour medicines that maintain dopamine tone for 24 hours. Remember, immediate release, it's given at regular intervals throughout the day because the half-life makes it that it goes up and down throughout your body. But there are medicines that are given once a day that last 24 hours. And that can be helpful for the nighttime hours too.
Okay, one last question, and this really has to be it. Are nightmares a result of Parkinson's?
Yeah, vivid dreaming is part of Parkinson's. People that don't go into deep sleep tend to have more vivid dreaming. Medicines like antidepressants can enhance sometimes vivid dreaming, but oftentimes those are needed too. So what do you do? Nightmares could be REM behavioral disorder, right? So REM behavioral disorder is you're acting out, you're talking in your sleep, you're moving, you're kicking. You can act out a dream so much that you jump out of bed and fall. And so, yeah, when we talk about nightmares as REM behavioral disorder, unfortunately, yes, we can have REM behavioral disorder that in Parkinson's, as we mentioned. And so as long as we can identify it, remember, hopefully our goal is not to kind of focus on all the things that can go wrong, but focus on all the things that we can do to fix them once they're identified. And that's why this conversation is a wonderful one to have, so that we can get to the bottom of what's going wrong. And then hopefully we've learned and empowered ourselves with information, knowing that there can be a therapeutic outcome to detecting a problem, right? So you go to your healthcare team and you say, look, this is what's happening in my sleep. Hopefully after today, you say, look, I have restless leg. I'm snoring. I wake up in the middle of the night. Am I wearing off, doctor? Could it be that? Should I use an as-needed therapy? Should I use an extended release? These are the sorts of conversations, hopefully this presentation kind of brought to the surface in our minds the different things that can go wrong, but only so that we can feel positive and optimistic about how to fix it.
Okay. Yeah, sir. Thank you very, very much. I mean, you're so clear and you're just a pleasure to listen to and very informative. Thank you to everyone who signed on. Remember this session will be available on our website in about 2 days. So if you missed it or you just want to see it again, go right to the website and sign on. And that's it. And hopefully we'll see you all for the next one in September. Thank you.
Thank
Night.
you so much. Have a nice night. Bye-bye.
Thanks, Yasser. Thank you.
You're very welcome. My pleasure. My pleasure.
Mine too. Thanks. All right. And we'll talk soon. Okay.
Perfect.
Okay, good.